Module Overview. To equip you with a detailed understanding of the procedures, clinical responsibilities, physiological principles, and systemic approaches involved in post-resuscitation care, including airway maintenance, hemodynamic stabilization, neurological support, and ethical considerations, while aligning with global accreditation standards such as the American Heart Association, AHA, European Resuscitation Council, ERC, and ISO 21001:2018 for educational quality in healthcare training. Module content. Definition and scope of post-resuscitation care, PRC. Post-resuscitation care, PRC, refers to the comprehensive medical, psychological, and ethical support given to a patient after return of spontaneous circulation, ROSC. This phase is critical in determining long-term neurological outcomes, organ function, and overall survival. PRC isn't just about keeping someone alive, it's about preserving brain, lung, kidney, liver, and cardiac functions while preventing secondary injuries. Key phases of post-resuscitation care. Post-resuscitation care comprises 4 critical phases: immediate stabilization, first hour post-ROSC, maintain airway, oxygenation, circulation, prevent rearrest, monitor ECG, BP, SpO2, immediate 12-lead ECG for possible STEMI, heart attack, ongoing support, 1 to 24 hours, intensive monitoring in ICU, therapeutic hypothermia if indicated, ventilatory support vasopressors for hypotension, neurological management, Glasgow Coma Scale, GCS scoring, pupillary response, brain, CT/MR, eye if needed, delayed neurological evaluation to allow for stabilization, long-term recovery and rehabilitation, physical, occupational, and speech therapy, psychological support, social services involvement, discharge planning. Prioritizing airway, breathing, and circulation. ABCS. Airway. Ensure patency. May require intubation. Breathing. Mechanical ventilation to maintain O2 saturation greater than 94% circulation. Manage hypotension, MAP, greater than 65 millimeters of mercury, ECG, IV fluids, vasopressors. Avoid hyperoxia or hypoxia. Both are detrimental post-ROSC. Oxygenation and ventilation strategies. Target SpO2, 94% to 98%. Avoid hyperventilation. It reduces cerebral perfusion pressure, EtCO2 monitoring. End tidal CO2 levels should be between 35 to 45 millimeter of mercury. Positive pressure ventilation must be balanced to prevent lung injury. Use of airway adjuncts. 1. Oropharyngeal airway, OPA, keeps tongue from blocking airway, used only on unconscious patients without gag reflex. 2. Nasopharyngeal airway, NPA, inserted through the nose, can be used in semi-conscious patients or when OPA is contraindicated. 3. Bag valve mask, BVM ventilation, delivers high-flow oxygen, requires skill and proper technique to create a tight seal, best with 2 rescuers, 1 seals mask, 1 squeezes bag. Barriers to effective rescue breathing. Poor seal of mask leading to ineffective ventilation. Obstructed airway not cleared properly. Vomiting. Aspiration during ventilation. Inadequate head positioning. Hyperventilation leading to decreased cardiac output. Hemodynamic monitoring and support. Continuous ECG monitoring for arrhythmias, blood pressure support, using vasopressors like norepinephrine or dopamine. Central venous pressure, CVP, may be monitored in ICU settings. Watch for rearrest, especially in myocardial infarction MI patients. Neurological care and prognostication. Pupillary light reflex, motor response, and EEG monitoring guide. Care therapeutic hypothermia, targeted temperature management may be initiated. 32 to 36 degrees Celsius for 24 hours. Post-ROSC neurological assessments are often delayed 72 hours post-resuscitation. Therapeutic hypothermia, targeted temperature management, TTM. Benefits: reduces metabolic rate, decreases inflammatory responses, minimizes cerebral injury. Risks: infection, arrhythmia, coagulopathy. Protocols: initiate within 4 to 6 hours. Post-ROSC, use ice packs, cooling blankets, or endovascular cooling. 8.8 Ethical and legal considerations in PRC consent for continued life-sustaining treatment. Do not resuscitate. DNR. Discussions. End-of-life care. If recovery is deemed unlikely, involve family and ethics committees when possible. Emotional and psychosocial support. Family members need immediate updates and emotional support. Patients may suffer post-ICU syndrome, anxiety, depression, PTSD. Healthcare professionals must engage social workers and psychologists early. Documentation and handover. Accurate and timely documentation is crucial. ROSC time, oxygen, ventilation, and perfusion data, interventions done post-resuscitation medications, and fluid administration, next of kin communication records, transfer documentation if moved to ICU or another hospital. Learning outcomes for Module 8. By the end of this module, you will be able to define and describe all stages of post-resuscitation care, prioritize interventions immediately following ROSC, recognize the importance of targeted temperature management TTM, identify neurological signs and understand delayed prognosis evaluation, address ethical, legal, and psychosocial issues in the PRC phase. Accreditation compliance. This module aligns with international CPR and critical care guidelines, American Heart Association, AHA, post-cardiac arrest care standards, European Resuscitation Council, ERC, post-ROSC care recommendations, UK Resuscitation Council, RCUK, hospital and pre-hospital guidelines, World Health Organization, WHO, critical illness and ICU protocols, ISO 21001:2018, educational organization management, ISO 29993:2017. Quality of learning services outside formal education.